So, welcome once again to the Dr. Bhatia's Academy. Today is a test and discussion session on respiratory failure. We have completed the chapter of respiratory failure in our live session. So, today let us see how much we have learned and how much we can retain and apply it practically, clinically in our question answer session. For downloading the app of Dr. Bhatia's Academy, you can scan the QR code. It is available on iOS as well as Android. So let's begin. The very first question is, we have a 58-year-old chronic smoker here presenting with progressive dyspnea and drowsiness. Now his ABG is showing a PO2 of 52 millimeters of mercury, that is hypoxemia, with a PaCO2 of 68 millimeters of mercury. That means there is hypoxemia with hypercapnia. There is acidosis, pH is 7.29. So it is rise in PaCO2 causing a low pH means respiratory acidosis. Now the bicarb is also on the higher side, that is 31 millimoles of per liter. That means we are dealing with a partially compensated state. So it is respiratory alkalosis with metabolic compensation, renal compensation. So the X-ray chest is giving us hyperinflated lungs with flattened diaphragm. So we have a state of hyperinflated lungs with flattened diaphragm. Which of the following best explains the underlying mechanism of his respiratory failure? So we have hypoxemia with hypercapnia. That means we are dealing with some type 2 respiratory failure. So is it because of the VQ mismatch due to pneumonia? Is it because of right to left intracardiac shunt? Is it alveolar hypoventilation with chronic CO2 retention? Or diffusion impairment across alveolar capillary membrane? Or is it because of peripheral chemoreceptor insensitivity? You can guess the answer. Yes, we know the answer very well. It is a condition of alveolar hypoventilation with CO2 retention. So we are dealing here with a condition of alveolar hypoventilation because rise in CO2, PaCO2 rise means we are dealing with a case of hypoventilation, alveolar hypoventilation. So alveolar hypoventilation refers to reduced ventilation leading to an inadequate removal of carbon dioxide and inadequate oxygenation. So ABG of a rise in PaCO2 indicating type 2, that is hypercapnic respiratory failure. A chronic respiratory acidosis as suggested by low pH and a rise in bicarb, which indicates renal compensation. Now chronic smokers will develop COPD, especially the emphysema, which leads to destruction of the alveoli and poor gas exchange. Hyperinflated lungs and flattened diaphragm also support a diagnosis of emphysema. In emphysema, the loss of elastic recoil and reduced alveolar surface area impairs ventilation and gas exchange. Correct? So hypoventilation leads to hypoxia with hypercapnia. And over the time, body will attempt to compensate via renal bicarb retention, leading to partially compensated respiratory acidosis. Correct? So far the question is correct and we all got it right. The associated drowsiness will be due to CO2 narcosis, high CO2 causing CNS depression. Peripheral chemoreceptors and shunting do not explain the elevated PaCO2 and chronic compensation. Thus, alveolar hypoventilation is the most appropriate answer. Let us look at the other choices given in the question and why they are not the answer. So, VQ mismatch due to pneumonia. Now, pneumonia will cause what? Shunting of blood because that area is not ventilated. So, pneumonia will cause shunting physiology and VQ mismatch will primarily happen because of alveolar consolidation that will affect oxygenation. Typically, it will cause hypoxemia, correct? But CO2 levels will remain normal because of there will be reflex hyperventilation. So PaCO2 of 68 is not consistent with acute VQ mismatch. Compensation with high bicarb is also not expected in acute conditions like pneumonia. Chest X-ray findings in pneumonia will show a consolidation or infiltration but not hyperinflation with a flattened diaphragm. Pneumonia-related VQ mismatch is more typical of type 1 respiratory failure, that is hypoxemia with normal PaCO2. The presence of drowsiness due to CO2 narcosis will suggest hypercapnia and not acute hypoxia. So can it be right to left intracardiac shunt? What happens in right to left intracardiac shunt? Conditions like ASD with Eisenmenger's complex, TOF, these will all cause what? Refractory hypoxemia, and that will cause low PaO2, which is seen in our patient also, but it will not improve with supplemental oxygen also, because whatever oxygen you give, the blood is not reaching the lungs at all. It is getting shunted directly from right to left. So PaCO2 remains still normal or low, not elevated, because the CO2 is not retained. Whatever CO2 is produced, it is exhaled. There is no evidence of cyanosis or clubbing or murmur to support a shunt. In case of chronic right to left shunt, what are the typical features? Cyanosis, clubbing and murmur. Now, chest X-ray in congenital shunts will often show cardiomegaly or increased pulmonary vasculature, but not an emphysematous lung. So shunting causes hypoxemia without hypercapnia. So it will not explain CO2 retention or elevated bicarb. So can it be diffusion impairment across the alveolar capillary membrane? Diffusion impairment happens when does it happen? In cases, pictures like you have ILD. So diffusion impairment causes exertional hypoxemia. So there is exertional dyspnea, exertional hypoxemia as seen in ILD, that is interstitial lung diseases, and not in emphysema. So it typically affects oxygenation more than the CO2 elimination, because CO2 has higher solubility. So diffusion impairment does not cause significant CO2 retention. It is not associated with chronic CO2 retention or elevated bicarbs. Chest X-ray will give a typical picture of fibrosis, that is interstitial lung disease, reticular fibrotic changes, and not a hyperinflated lung. Emphysema affects diffusion, yes, it does, by destroying alveolar walls, but predominantly it causes air trapping and not a diffusion defect. So what about peripheral chemoreceptor insensitivity? Peripheral chemoreceptors, they respond to hypoxia and not to hypercarbia on CO2. So insensitivity to hypoxia is rare and not a typical cause of chronic respiratory failure. It would not explain the chronic CO2 retention. The moment there is hypoxia, the key peripheral chemoreceptors ask the patient to hyperventilate. So chronic CO2 retention or compensation is not seen here. There is no neurological or pharmacological context to suggest a chemoreceptor dysfunction. So it is not associated with hyperinflated lungs or a feature of COPD. CO2 retention due to chemoreceptor issue is theoretical and uncommon. Mechanical factors like airway inflow limitation are more relevant. No evidence of conditions like Ondine's curse or central hypoventilation syndrome has been suggested here in this elderly smoker. So what is the take-home message? What is your LMRP? Chronic CO2 retention, if you come across a case of hypoxemia with a chronic hypercapnia with drowsiness and hyperinflated lungs in a smoker patient, points to alveolar hypoventilation due to COPD, especially emphysema. Okay, let's see our next question. Now here you have a 4-year-old boy, a 4-year-old child presenting with fever, stridor, drooling of saliva, and severe respiratory distress. So what is happening? Some infection, upper airway tract obstruction because there is stridor and saliva drooling. So we have something like epiglottitis. So that will cause what? Obstruction to the airway, causing Hypoxia, again with hypercapnia, with a low saturation. So saturation is only 84% here. But the X-ray is still normal, with a normal chest X-ray. So what is the most likely cause of hypoxemia here? Why air is dropping? Tell me, is it because of increased alveolar arterial gradient due to VQ mismatch? Or a normal alveolar arterial gradient due to upper airway obstruction? Or a diffusion impairment? Intrapulmonary shunts due to ARDS? Or impaired hemoglobin oxygen affinity? Normal gradient, because it is an upper airway obstruction, so there will be a normal gradient due to upper airway obstruction. The child is presenting with what? Acute upper airway obstruction, most consistent with acute epiglottitis or bacterial tracheitis, anything which is blocking the upper airway tract. Stridor will indicating obstruction at the level of larynx or above, suggesting some extrathoracic obstruction. Fever with drooling of saliva plus inspiratory stridor strongly suppose some upper airway obstruction with infection. Hypoventilation is occurring because the upper airway is obstructed, causing mechanical obstruction. So there is hypoxia with hypercapnia. So hypoxia with hypercapnia is happening because there is obstruction. So alveolar PaO2 is also low and arterial PaO2 is also low. So the gradient remains normal. The A minus A, both are dropping. So the A minus A values remain normal. So what are we dealing here? Hypoxia, hypercapnia with a normal AA gradient is what? Another type 2 respiratory failure case. So CO2 retention confirms hypoventilation as the major issue. In pure hypoventilation, the alveoli are otherwise intact. So what happens? The AA gradient remains normal. The alveolar arterial gradient is used to differentiate the mechanism of hypoxemia. We know that we find out the difference whether the gradient is normal or raised to find out the mechanism of hypoxemia. For example, whether it's a VQ mismatch or a shunt or a diffusion. So in this case, the hypoxemia is due to decreased ventilation and not because of impaired gas exchange at the alveolar capillary level. Therefore, AA gradient is normal, and this helps in distinguishing hypoventilation from other mechanisms like ARDS or shunting, where the gradient is raised. Upper airway obstruction will not increase the gradient because alveolar oxygenation and capillary diffusion are unaffected. So what are the other options? Increased AA gradient. This we just read. It cannot be increased AA gradient. So VQ mismatch occurs when areas of lung are ventilated but poorly perfused, or vice versa. That is poorly ventilated with high perfusion. For example, conditions like asthma and pneumonia. So it typically leads to hypoxemia with increased gradient, which is not seen in this patient. This child has hypoventilation with CO2 retention, pointing to global ventilatory failure, not a localized condition. So VQ mismatch will usually lead to hypoxemia without significant hypercapnia and with increased gradient, of course. So VQ mismatch is not associated with drooling or stridor, which is more typical of the lower airway or the parenchymal disease. Chest X-ray in VQ mismatch may show infiltrates or overinflation, but not a normal X-ray. Normal X-ray again favors upper respiratory tract involvement. Normal AA gradient in this case rules this out. Diffusion impairment due to pulmonary fibrosis. Now, diffusion impairment again we just studied. It will affect the gas exchange across the alveolar capillary membrane. It will cause low PaO2 and increased gradient, especially during exertion. So pulmonary fibrosis is a condition, chronic condition, not an acute condition, which is present in this 4-year-old child. 4-year-old child is very small to label as any chronic condition. So it typically presents with dry cough. Chronic fibrosis will have dry cough, clubbing, restrictive PFTs, but not stridor or drooling. Chest X-ray will also show interstitial infiltrates and not a normal fill. Diffusion impairment does not usually cause acute stridor or hypercapnia. Thus, this picture is consistent with clinical and radiological finding that there is upper airway obstruction. Intrapulmonary shunts due to ARDS. Now, shunting physiology involves perfusion without ventilation. So, there is perfusion. Shunt means that air is not coming and the blood is just coming and going. So, blood is just as it came, it left. So, there is shunting of the blood without ventilation, leading to a very low PaO2. And no, it does not respond to oxygen therapy because there is a block. So it is associated with increased gradient and typically presents with diffuse infiltrations on the chest X-ray. ARDS is a diffuse alveolar injury, unlikely in an otherwise well child with acute stridor and normal X-ray. No history of sepsis or trauma or aspiration or common triggers for ARDS. Also, ARDS will not cause stridor or drooling, which are supraglottic signs. Shunting is a lower respiratory pathology, not an upper respiratory pathology. Now, the next choice is impaired hemoglobin oxygen affinity. This refers to altered hemoglobin function like carbon monoxide poisoning or methemoglobinemia. These conditions will cause tissue hypoxia despite normal PaO2 and AA gradient. So everything remains normal here, but the tissue hypoxia still happens because of carbon monoxide poisoning or methemoglobinemia. PaO2 is low, which does not match impaired affinity syndromes. Also, there is no exposure history and clinical signs, like for example for cyanosis without hypoxemia or cherry red skin. They're all such clinical signs are all absent. ABGs showing hypoxemia with hypercapnia pointing towards a ventilation issue, not an abnormal hemoglobin issue. Now, chest X-ray and clinical context they also do not fit the methemoglobinemia or the carbon monoxide poisoning. So your LMRP is in pure hypoventilation picture because of upper airway obstruction, that is epiglottitis, tracheitis, hypoxemia with normal gradient and normal CO2 retention. So hypoxemia with CO2 retention but normal gradient, that is type 2 respiratory failure, is seen in upper airway obstruction, that is epiglottitis or tracheitis. So this much is clear. Let's move to the next question. Question number 3. Now here we have a mountain climber. He is rising to 14,000 feet without prior acclimatization. So he just came and started rising up and he reached 14,000 feet without resting and without allowing his lungs to get acclimatized. So what did happen? He developed sudden headache, dizziness and tachypnea. ABG is showing hypoxemia with a normocapnia. So what is the primary reason for the hypoxemia? Tell me. This is very simple. At high 14,000 altitude, the inspired oxygen itself is low. So that is causing hypoventilation. Correct. So reduced inspired oxygen, partial pressure causing hypoventilation. So what is happening here at high altitude of 14,000 feet? The atmospheric pressure drops, leading to decreased inspired partial pressure of oxygen. The atmospheric oxygen is itself low. So there is less of the air reaching the lungs. So the lungs are normal. The driving pressure for oxygen diffusion into the blood is reduced, resulting in hypoxemia. So that air is not coming with that pressure. Now the climber develops tachypnea as a result of compensatory response, leading to, because of the tachypnea, the CO2 is exhaled out. So there is hypocapnia. So hypoxemia or hypoxia along with hypocapnia. So the low PaO2 and low PCO2 with normal lungs are indicative of primary environmental hypoxia. because of decreased atmospheric oxygen pressure. This is not due to alveolar pathology. There is no alveolar defect. The AA gradient will remain normal. So there is hypoxemia with hypocapnia and with normal gradient. Since the alveoli are intact and ventilated, the gas exchange surface remains normal or functional. Hypoventilation is relative. Lungs cannot extract enough oxygen due to low ambient pressure, not due to defect in the respiratory mechanisms. Now, these features are typical of acute mountain sickness, often seen without prior acclimatization. This only happens if you quickly rise to the mountains without allowing your lungs to get used to it. Now, the low PaCO2 reflects respiratory alkalosis. We know the formula pH is equal to bicarb upon PCO2. So, if the PCO2 is dropping, pH will rise. So, respiratory alkalosis due to hyperventilation in response to hypoxia. Treatment will involve descent, come back, नीचे आ जाओ, oxygen therapy, and sometimes acetazolamide is given to stimulate the ventilatory drive. Thus, the primary cause of hypoxemia is reduced inspired oxygen partial pressure and not a pulmonary or a cardiac abnormality. The AA gradient is normal because both alveolar and arterial PO2 are proportionally reduced. दोनों ही कम हो जाएंगे क्योंकि एटमॉस्फेयर में ही ऑक्सीजन नहीं है. Let's look at the other choices in the question. So there is increased gradient. Now, increased gradient due to VQ mismatch, we discussed in the last question also. VQ mismatch only occurs when alveolar ventilation and perfusion are not matched. For example, COPD and pulmonary embolism. It leads to hypoxemia with increased gradient, which is not seen here in altitude-related problems. Hypoxemia is due to low ambient atmospheric pressure of oxygen, normal ventilation, but abnormal, not the abnormal ventilation here or the perfusion mismatch. So this is all happening because of the atmospheric oxygen decreased. There is no evidence of lung disease or airway pathology. PaCO2 will remain low because there is hyperventilation, which suggests adequate alveolar ventilation and not a mismatch. Chest imaging would typically be normal here again in altitude sickness. So there is no underlying infiltration or pathology. Right to left shunts, once again, right to left shunts will allow what? Deoxygenated blood to bypass the lungs and enter into heart, that is systemic circulation. Now they cause hypoxemia with normal PCO2 and the hypoxia is not corrected with supplemental oxygen. In this climber, PaCO2 is low, indicating effective ventilation, not consistent with shunt pathophysiology. So here in this mountain climber, there is no pathophysiology. It is just that the atmospheric air pressure is low. With no history of congenital heart disease or cyanosis, we can rule out the right to left shunt. Right to left shunt would also result in persistent desaturation unrelated to the altitude. So in case of right to left shunt, like in TOF you have seen, there is aorta, this will override the right and the left ventricle. So there is, irrespective of the altitude, this right to left shunt will keep on going. Now this is an acute environmental exposure, not a congenital or a structural defect. So this condition, this case is just because of sudden rise to height 14,000 feet. Then the impaired diffusion, again the same problem. Diffusion limitation, that is pulmonary fibrosis, causes increased gradient and exertional desaturation. It does not occur acutely in healthy individuals. It's a chronic parenchymal lung disease. The climber had no pre-existing lung disease or exposure to toxic inhalants, normal PaCO2 and lung compliance, and would not support diffusion impairment. Chest imaging would show reticular opacities in the case of fibrosis, and no such evidence or chronic features are present here. So this cannot be the case. It is a simple case of atmospheric pressure, partial pressure of oxygen has dropped. Now, the hemoglobinopathies, that is reduced oxygen carrying capacity. This again refers to conditions like anemia, carbon monoxide poisoning, or abnormal hemoglobins. These reduced oxygen content, but not necessarily PaO2. The oxygen content is decreased, definitely. But the partial pressure of oxygen, which is usually the dissolved oxygen, it remains normal. In carbon monoxide poisoning, PaO2 may be normal, but the saturation is reduced due to dysfunctional hemoglobin. Now, the patient shows low PaO2, that's hypoxemia, suggesting a problem with oxygen entry, not hemoglobin capacity. There is no clinical history of anemia, carbon monoxide exposure, or methemoglobinemia. So, hemoglobin function is likely normal, and tachypnea is in response to low atmospheric oxygen. Here, I stands for atmospheric oxygen. So, what is your LMRP? At high altitude, hypoxemia occurs due to reduced inspired partial pressure of oxygen with a normal gradient and compensatory hyperventilation. I think we all are clear till here. सबको समझ आ रहा है क्या आप कर रहे हैं हम? तो हम आगे बढ़ें. So let's move to the fourth question. We have a 65-year-old male who develops acute shortness of breath following prolonged immobilization after surgery. So, acute shortness of breath following immobilization, showing hypoxia, hypocapnia, saturation is dropped, X-ray still is normal, and D dimers are elevated. Now, elevated D dimer with a difference in PO2 and saturation. The PO2 is also low and the saturation is also low. So let us have a condition where we are having elevated D dimer, means we are probably dealing with what? Pulmonary embolism. So which of the following mechanisms will explain this hypoxemia? Dead space ventilation due to pulmonary embolism. This is the answer. So this is dead space ventilation due to pulmonary embolism. Pulmonary embolism is a classical complication of post-operative state, post-op immobilization, which is characterized by acute onset dyspnea, hypoxemia, and tachypnea. In pulmonary embolism, a thrombus obstructs a pulmonary artery, resulting in ventilation without perfusion. So what is happening here? This is alveoli, and there are capillaries somewhere here, and there's an emboli here. They are blocking it. So the air is here. The ventilation is normal, but perfusion is less. So what we have? We have dropped perfusion, but ventilation still remains normal. So this is what is happening. The dead space ventilation. Ventilation is getting wasted. So it is a dead space ventilation. This will cause a VQ mismatch, leading to increased gradient. So this time what we have? Hypoxemia, normocapnia with increased gradient. That is type 1. And hypoxemia with increased gradient, that is type 1 respiratory failure. So despite of adequate ventilation, there is PaCO2 is normal, gas exchange is impaired in the affected segment because there is no blood to exchange the gases. So the unaffected regions may hyperventilate, resulting in low PaCO2, but they cannot compensate for the loss of oxygen. So pulmonary embolism will cause tachypnea, hypoxemia, and despite of normal chest X-ray. D dimer elevation again supporting the diagnosis of pulmonary embolism. Hypocapnia, normocapnia with hypoxemia, pulmonary embolism due to reflex hyperventilation. Hypoxemia is primarily due to wasted ventilation, that is increased physiological dead space. Some areas may appear near complete perfusion loss because of the effect and causing reduced effective gas exchange. This pattern occurs without alveolar infiltrate, hence the chest X-ray is normal. Dead space ventilation due to pulmonary embolism. That is what the answer is. Once again, why not diffusion at alveolar membrane? Diffusion block, as in case of ILD, impairs oxygen transfer across the membrane and causes exertional hypoxia with chronic disease. It is not something which happens acutely. It causes increased gradient, but not with a normal X-ray. ILD will show reticulonodular opacities. Diffusion issues do not explain the acute presentation or elevated D-dimer. Diffusion picture will always be a chronic picture with no parenchymal fibrosis or membrane thickening in pulmonary embolisms. Now, hypoventilation. Again, hypoventilation will cause hypercapnia. So, hypoventilation will cause hypercapnia and respiratory acidosis, which is not here. Here, the PSU2 is normal. So, opioid-induced hypoventilation causes type 2 respiratory failure with both hypoxia and hypercapnia. Now, this patient has normocapnia. So, there is adequate ventilation in parts of the lung. With no history or clinical evidence of recent opioid administration or overdosage, opioid-related respiratory depression is again central in mechanism, not due to lung perfusion defects. D-dimer elevation will not happen in opioid usage. Now again, why not shunt? Same, we are repeating the same things. Respiratory system is a very simple system. The same mechanisms will answer all your questions. So again, the right to left shunt due to ARDS. ARDS was what? It is a non-cardiogenic pulmonary edema. ARDS is diffusion of the proteinaceous material between the alveoli and the capillary. So it's a non-cardiogenic pulmonary edema. Diffuse alveolar damage and bilateral chest infiltrates will be seen on X-ray. It will cause intrapulmonary shunting due to fluid-filled alveoli leading to refractory hypoxemia. This patient has a normal X-ray which rules out ARDS. No clinical triggers like sepsis or aspiration or any sign of ARDS. ABG will show hypoxemia, but ARDS usually presents with severe respiratory distress and bilateral crackles. D-dimer elevation is again not a feature of ARDS. Now, hemoglobin abnormalities, methemoglobinemia, for example. Methemoglobinemia definitely will cause functional anemia because hemoglobin cannot bind oxygen effectively. It usually presents with cyanosis, low saturation but normal PO2. So this is very, very important point here. Methemoglobinemia has a difference of PO2 and SaO2. There's a difference in the saturation and the partial pressure of oxygen. So PO2 is low, indicating here the PO2 is low. Whereas in methemoglobinemia, saturation is low, indicating a problem with oxygenation and not with hemoglobin function. It is often drug-induced like methemoglobinemia because of dapsone or because of nitrates. With no such history, here is no history of dapsone administration or nitrate administration. ABG will show a discrepancy between SaO2 and SpO2, that is PO2, that is saturation gap. This is known as saturation gap, which is not mentioned here. Methemoglobinemia is a rare post-operative and does not elevate the D-dimers again. So take home message, the last minute revision point. Pulmonary embolism causes hypoxemia due to dead space ventilation and VQ mismatch. Dead space ventilation because the perfusion is less. With normal PaCO2 and hypoxemia with elevated D-dimer and normal chest X-ray. Okay. So coming to the last question of the day. A 32-year-old woman presenting with confusion and cyanosis. Now here look once again. Partial pressure of oxygen is normal, but the saturation is low. We just studied the saturation gap. What is saturation gap? Difference between partial pressure of oxygen and saturation. So partial pressure of oxygen is normal, that is dissolved oxygen is normal, but the bound oxygen is less. So why it is so? Because of binding defects of the hemoglobin. So this condition, even without reading the question further, I can say I am dealing with methemoglobinemia. So PaCO2 is normal. Blood appears chocolate brown in color. So if you have attended my class last time, you will know what is the chocolate brown color of the blood, how does it look like. So which of the following is the most likely diagnosis? Without even looking at any other choices, I know the answer. And I am sure you all also know the answer. We are dealing with methemoglobinemia. So what is hemoglobinemia? Here we know that each molecule of hemoglobin has 4 heme molecules, and each heme molecule is bound to a ferrous state of iron. But if one of it gets converted into ferric state, that is Fe3 plus. So the ferric formation methemoglobinemia occurs when iron in the hemoglobin is oxidized from ferrous to ferric, forming methemoglobin. The ferric form of iron cannot bind oxygen. And also it will not allow deloading of the oxygen from the other sites of the heme molecule, other heme molecules. So it results in functional anemia. So oxygen is present, that is PO2 is normal, but cannot be delivered to the tissues, leading to hypoxia and cyanosis. So the hallmark finding is a discrepancy between PaO2, that is normal PO2, and saturation is low. So PaO2 reflects dissolved oxygen and not the bound oxygen. So the saturation gap, that is normal PO2 with low pulse oximetry reading, is classical for methemoglobinemia. Chocolate brown color of the blood is a characteristic sign because of the altered light absorption. Causes include exposure to oxidizing agents like nitrates, depson, sulfonamides, or local anesthetics like benzocaine. Patient often presents with cyanosis, confusion, headache, dyspnea, and symptoms may progress rapidly. Arterial blood gas will show normal oxygen tension but with low saturation. Pulse oximeter will often reveal falsely low, usually around 80 to 85% range, regardless of the true saturation. Diagnosis is confirmed with co-oximetry, which directly measures methemoglobin levels. Now, the treatment will include methylene blue. The antidote, the typical antidote of methemoglobin is methylene blue, which helps to reduce the methemoglobin back to the functional hemoglobin. Therefore, the clinical picture and lab findings are diagnostic of methemoglobinemia. Other options, why not it is carboxyhemoglobinemia? Carboxyhemoglobinemia means binding of carbon monoxide. Now, carbon monoxide poisoning, where CO binds to hemoglobin with high affinity, that will displace the oxygen. It will present with normal PO2, but falsely normal or high SpO2 and very low true saturated oxygen. Unlike methemoglobinemia, blood is typically cherry red and not chocolate brown. Patient may present with headache, dizziness, nausea, altered mental status. Cyanosis is less prominent. The saturation gap is present, but appearance of the blood and oximeter readings they differ. Carboxyhemoglobinemia causes leftward shift of the oxygen dissociation curve, impairing the tissue delivery. So it turns leftwards. Anemia due to acute hemorrhage. Now, acute anemia will reduce the total oxygen carrying capacity, but PO2 and SaO2 remains normal because it is a total loss in the total content of the blood. So there is no saturation gap, no change in the blood color. Cyanosis is not a feature unless hemoglobin levels are extremely low. It does not cause chocolate brown blood or a discrepancy between the partial pressure and the saturation of oxygen. Confusion may occur due to hypoperfusion, but cyanosis plus normal PO2 and low saturation is not explained by hemorrhage. Hence, this diagnosis does not match the ABG diagnosis and the clinical signs. Histotoxic hypoxia due to cyanide poisoning. Now, this is another condition where there is tissue hypoxia. The blood is normal, there is no hypoxemia. In cyanide poisoning, oxygen delivery is normal. Cells cannot use this oxygen. This is histotoxic hypoxemia. Now, ABG will show elevated venous oxygen content and lactic acidosis, but saturation and PO2 remains normal. No saturation gap, blood color remains bright red due to unused oxygen. Cyanide poisoning will present altered mental status, seizures, cardiovascular collapse, and normal ABG saturation values. Chocolate brown color is not there of the blood. Thus, while cyanide poisoning causes confusion, it does not match the saturation gap or cyanosis here. Acute pulmonary embolism. We just read pulmonary embolism. It causes wasted ventilation. So PE typically presents with acute dyspnea, hypoxemia, and often tachycardia, chest pain. ABG will show low arterial oxygen and low or normal PaCO2, not normal PO2 with low saturation. So there is hypoxemia with hypocapnia. No saturation gap is present. Blood color remains normal. Confusion can occur, but cyanosis in PE is usually accompanied by dyspnea, chest pain, and signs of right heart strain. And the clinical signs and ABG findings in this case do not match the pulmonary embolism. Pulmonary embolism will not cause brown blood or falsely low pulse oximeter readings. Hence, this is not the answer. So, what is your LMRP? Methemoglobinemia presents with normal PO2, low saturation, chocolate brown color of the blood, and a classic saturation gap. Treat with methylene blue. The perfect antidote of methhemoglobin is methylene blue. So we are stopping here, the 5 questions. I hope this much is clear to you. We have discussed type 1 respiratory failure revised, type 2 respiratory failure revised. We have revised methemoglobinemia. We have revised your cyanosis, your acute respiratory, upper respiratory tract blockage. So, this was our chronic CO2 retention with hypoxemia, drowsiness, hyperinflated lung. So, this is because of emphysema, hypoxemia, hypercapnia, type 2 respiratory failure with normal gradient. This was pure hypoventilation, upper airway obstruction, causing hypoxemia, hypercapnia, and normal gradient, that is type 2. This was mountain sickness or at high altitude because of the atmospheric oxygen is reduced. So we have at high altitude hypoxemia because of the decreased partial pressure and a normal gradient again and a low PaCO2. So everything is, here we have everything low, but a gradient also remains normal. This is because of the pulmonary embolism. Again, pulmonary embolism is causing wasted ventilation. So we have hypoxemia with normal PaCO2 and a rise in D dimer, which is very strongly favoring pulmonary embolism. And then last was your methemoglobinemia because of ferrous converted into ferric, and there is a saturation gap happening. I hope we are clear till now. So far we all are clear. With that, we stop here. The respiratory failure, the topic I hope is very, very clear to you. Still, if it is not clear, you can go through the readings videos all over again. You can go through these questions again. Still, if there are more questions and which are not clear, please write to us. Dr. Bhatia's Academy is here to help you. We can redo the topics whenever you want. And for the next session, next topic, we will inform you soon which class, which topic will be taken. Probably we will be taking some session on from cardiology. So 4th Tuesday, let's catch up again with some topic of cardiology. Bye-bye. Good day. Take care. And thank you so much for being here with me.